Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Imagine for a moment that you're managing a patient with a progressive fibrotic lung disease.
Right. It's often described by clinicians as watching a slow-motion train derailment.
Exactly. I mean, you know the crash is happening, you know the trajectory, and despite the standard therapies we have available, you can really only do so much to slow it down.
Yeah, it's incredibly frustrating for everyone involved.
It really is. So when a major trial drops that suggests a brand new way to, tap the brakes on that progression, we absolutely have to pay attention.
Oh, without a doubt.
Welcome, everyone, to another deep dive. Today, we're functioning sort of like attending level rounds. We are looking at the TETON-2 trial, which was published in the New England Journal of Medicine in March 2026.
And before we get lost in the pathophysiology or, the statistical weeds, let's just establish the bottom line up front.
The BLUF, right?
Exactly, the BLUF.
Yeah.
What you really need to know right out of the gate is this. TETON-2 is an important practice-relevant trial. But, it is not a universal start on everyone tomorrow kind of result.
Right, we have to temper expectations a bit.
We do. Essentially, it showed that using inhaled treprostinil in patients with idiopathic pulmonary fibrosis, or IPF, was associated with a significantly smaller decline in FVC over 52 weeks.
And it also showed fewer clinical worsening events, right?
It did, yes. However, there was no definitive mortality or acute exacerbation win in this data. And crucially, the treatment burden and the tolerability matter immensely.
Because of the cough, right?
Exactly. The persistent cough associated with this inhaler is very real. We also need to understand that the 2021 INCREASE trial is the vital backstory here.
Oh, right, the one that showed benefit in PH-ILD.
Precisely. Which kind of explains why researchers pursued it for IPF in the first place.
That is the perfect anchor. So, to respect your time on rounds today, we're going to structure this discussion around three main learning goals.
Sounds good.
First, we will unpack the trial design. Who exactly was studied and under what conditions. Second, we will interpret the primary and secondary results, specifically looking at why we have to be incredibly careful not to overclaim a mortality benefit.
That's a huge point.
It really is. And third, we will translate this directly to the bedside, weighing the heavy side effects against the physiological benefits for your patients.
Perfect.
So before we dive into the data, just take a second and activate your prior knowledge. Think about your own patients with lung fibrosis. When you are evaluating a new therapy, what matters more to you and to them?
Right. Is it the raw numbers on their pulmonary function tests?
Or is it their day-to-day symptom burden and quality of life? Keep that tension in the back of your mind as we go through this.
That's exactly the right clinical mindset to maintain as we evaluate this research.
So let's set the stage by talking about the villain of the story. The disease itself, IPF, is just devastating.
The relentless.
Yeah. The delicate, spongy, oxygen-exchanging tissue of the lungs becomes relentlessly thick, stiff, and scarred over time. And the prognosis is notoriously poor.
Yeah. If left entirely untreated, the median survival is generally just 3 to 5 years.
Now, we do have background antifibrotic therapies available, right? Specifically nintedanib and pirfenidone, which have been standard of care for a while now.
We do, yeah.
But, they aren't cures, right?
Oh, far from it.
Yeah.
They are foundational, absolutely. But they really only slow the progression of the scarring. They do not halt it, and they certainly don't reverse it.
Right.
The disease remains progressive, which is why the pulmonary and critical care communities are on this constant hunt for additive therapies. And, that brings us to the crucial precedent, the clinical backstory that led to TETON-2.
The INCREASE trial.
Exactly. Back in 2021, the New England Journal of Medicine published the INCREASE trial.
Right, and we need to clarify that the INCREASE trial did not actually study pure IPF.
No, it didn't.
It looked at PH-ILD, which stands for pulmonary hypertension due to interstitial lung disease. Basically, high blood pressure in the pulmonary arteries that is driven by the underlying scarring and hypoxia in the lungs.
Correct. In that 16-week study, they enrolled 326 patients with PH-ILD, and they found that administering inhaled treprostinil improved the distance patients could walk in 6 minutes.
The 6-minute walk distance?
Yes. It improved it by an average of about 31 meters compared to placebo.
Wow, okay.
It also lowered NT-proBNP levels, which is, a key blood biomarker that indicates heart strain, by 15%.
And what about the placebo group?
Well, the placebo group saw a massive 46% increase in that same marker.
Oh, wow.
And importantly, it significantly reduced overall clinical worsening.
Okay, let me pause you right there because I want to push back on the underlying logic for a second.
Sure, go for it.
Treprostinil is a known vasodilator. Its primary day job is to open up blood vessels to lower pressure. So in the INCREASE trial, using it to treat pulmonary hypertension makes total physiological sense. You are relaxing the vascular bed.
Exactly.
But in TETON-2, the researchers pivoted to testing this exact same drug in pure IPF, where the primary driver of disease isn't vascular resistance, but physical, irreversible scarring of the lung tissue.
Yes.
So why on earth would you use a vasodilator to treat fibrosis? I mean, isn't that like using a plumber's wrench to fix a cracked foundation?
It is a totally fair critique, and it is exactly what many clinicians asked when the TETON program was first announced. But the data from the INCREASE trial, along with its subsequent open-label extension study, gave the medical community a massive clue.
A clue? Like what?
Well, the data didn't just show improved hemodynamics. It strongly suggested that treprostinil might possess actual antifibrotic properties, not just vascular ones.
Okay, but how does that actually work? Normally, a vasodilator just widens the pipes. Are you saying this drug physically stops the scarring process?
Preclinical data points to exactly that mechanism, yeah. The drug targets specific prostanoid receptors that modulate fibrogenetic pathways in the lungs.
Interesting.
If we want a mental model, it basically acts like a stop work order at a cellular construction site.
I like that.
Right. It binds to the receptors on the cells that produce scar tissue and essentially tells them to stop pouring concrete. It isn't just a plumber's wrench opening up pipes. It is actively interfering with the biology of the fibrosis itself.
That is fascinating. So the drug has a hidden secondary mechanism.
Exactly.
That totally reframes why moving to the TETON-2 trial was a highly logical next step. If you have a stop work order for scar tissue, you need to prove it works in a dedicated IPF population.
Exactly. And they designed TETON-2 to be as rigorous as possible.
Okay, let's get into the design.
This was a phase 3, randomized, double-blind, placebo-controlled trial. They enrolled 593 adults with guideline-confirmed IPF.
And what did the demographics look like?
Looking at the demographics, the cohort was predominantly male, making up about 80% of the participants, with a mean age of around 71.7 years.
Okay, typical for this disease.
Very typical. To qualify for the trial, patients had to have a baseline FVC forced vital capacity of at least 45% of their predicted normal value.
All right, I want to stop on a specific detail I noticed in the methodology. Roughly 75% of the patients enrolled in this trial were already taking the standard background antifibrotics we mentioned earlier.
Yes, either nintedanib or pirfenidone.
Right. So if 3/4 of the patients are already on established anti-scarring drugs, doesn't that heavily muddy the waters for the primary endpoint? How do we know TETON-2 isn't just piggybacking on the success of the older drugs?
That's a great observation. And strictly from a laboratory perspective, it does make isolating the single drug's effect slightly more complex.
Right, because you have multiple variables.
Exactly. But practically speaking, for the clinicians listening, allowing background therapy makes this trial vastly more relevant to the real world.
How?
Well, in a modern pulmonology clinic, you are not going to take a progressing IPF patient off their standard of care medication just to test a new, unproven inhaler.
Oh, absolutely not. That would be borderline unethical.
Right. So TETON-2 was designed to answer the much harder, more clinically relevant question. Does adding inhaled treprostinil on top of existing baseline therapies provide measurable additive value?
That is a crucial distinction. We are looking for additive value in a real-world setting, not just some standalone miracle in a vacuum.
Exactly.
So how did they actually administer this?
Patients were randomized to receive either placebo or the active drug over a full 52-week period. The active drug was titrated up slowly with a target dose of 12 breaths, which equals 72 micrograms administered 4 times daily using an ultrasonic nebulizer.
4 times daily. We really need to underline that for a moment.
Yes, we do.
Because this is not a simple pill you swallow with your morning coffee. Inhaling medication through a nebulizer 4 times every single day is a massive daily commitment for a patient who is already likely struggling with severe breathlessness and fatigue.
Is a heavy logistical and physical burden, without question.
So let's look at what that massive commitment actually bought these patients. Let's get to the primary endpoint. What happened to their forced vital capacity after a full year of inhaling this medication?
Well, the primary endpoint was the change in absolute FVC. At week 52, the patients in the treprostinil group lost a median of 49.9 milliliters of lung capacity.
Okay, about 50 milliliters lost.
Right. The patients in the placebo group lost 136.4 milliliters.
Wow, that's a big difference.
It is. That gives us a between-group difference of 95.6 milliliters, favoring the active drug, with a highly significant p-value of less than 0.001.
Okay, let's clearly translate that for bedside reality. The drug did not reverse the scarring.
No, it didn't.
The patients still lost lung function. They lost about 50 milliliters of it. But they lost it significantly slower than the patients on the placebo.
That is the vital distinction. It is a disease-modifying signal.
Right.
In a relentlessly progressive disease where you continually lose lung volume, preserving nearly 100 milliliters of FVC over the course of a year is a tangible, clinically meaningful victory.
It really is.
And to address your earlier skepticism about the background medications muddying the waters, the researchers ran multiple sensitivity analyses.
Oh, they did?
They did. The benefit was seen consistently across various subgroups. Most importantly, the signal held up whether the patients were on background antifibrotic therapy or not.
Okay, so the FVC numbers look definitively good on a spreadsheet. But, if I am the patient sitting in the exam room, I honestly don't care about milliliters.
No, of course not.
I care if this drug is going to keep me out of the hospital or keep me alive longer. Did the researchers track those harder clinical outcomes?
They did, and they measured it through a secondary endpoint called clinical worsening.
Okay, clinical worsening.
Yeah, this was a composite metric, meaning it grouped several bad outcomes together. It included death, hospitalization for a respiratory cause, or a severe rapid drop in FVC.
And what did they find?
The results here were also positive. Clinical worsening occurred in 27.2% of the treprostinil group, compared to 39.0% in the placebo group.
I see in the paper it notes a hazard ratio of 0.71 for that metric.
Yes.
So essentially, we are looking at a 29% drop in the risk of experiencing one of those terrible events over the year. That sounds like a solid, indisputable win.
It is a win, but this is exactly where we have to be incredibly disciplined about how we interpret modern clinical trials.
Why is that?
Because the very next secondary endpoint they evaluated was the time to an acute exacerbation of IPF. And here, there was no substantial, statistically significant difference between the two groups.
Interesting. And because of the way these trials are structured statistically, that single miss has massive ripple effects on everything else they measured, right? Can you explain that mechanism?
Yeah, it is due to a rule called hierarchical testing.
Right, hierarchical testing.
When you design a rigorous trial, you pre-plan a strict, ordered cascade of secondary endpoints. If you hit statistical significance on number 1, you're allowed to test number 2.
Makes sense.
If you hit number 2, you move to number 3. But the moment you fail to reach statistical significance on an endpoint, which in this case was acute exacerbations, you must stop your formal statistical testing. You break the chain.
I love pointing this out because it prevents researchers from just, scrolling down the massive spreadsheet of data, ignoring the misses, and loudly promoting any random metric that happens to look good.
Exactly.
There is no statistical window shopping allowed.
Precisely. No statistical window shopping. And because the testing chain was broken at acute exacerbations, the researchers cannot make definitive, statistically proven claims about mortality, which was located lower down on their pre-planned hierarchy list.
Got it. But what were the raw numbers for mortality, just for context?
Just for context, there were 19 deaths in the treprostinil treatment group compared to 24 in the placebo group.
Okay.
It translates to a hazard ratio of 0.77.
Yeah.
It certainly trends in a favorable direction, but we cannot legally or scientifically call it a proven mortality benefit based on the rules of this trial.
Right.
And the exact same limitation applies to the quality of life scores and the diffusing capacity metrics.
That discipline is so vital. It stops us from overpromising to our patients based on trends rather than proven facts.
It really does.
So, summarizing where we are, we have a therapy that taps the brakes on FVC decline and reduces overall clinical worsening.
Yes.
But it is not a proven mortality cure, and it doesn't definitively prevent acute exacerbations.
Got it.
That leads us directly to the bedside reality check, because physiological efficacy on a chart doesn't matter at all if the patient throws the nebulizer in the trash after a week, because it makes them miserable.
Oh, absolutely. And that is arguably the biggest clinical hurdle with TETON-2. The safety and tolerability data are, well, they're sobering.
Tell me about it.
The burden of treatment is immense, primarily driven by one side effect, which is cough. A persistent cough was reported by 48.3% of the patients take inhaled treprostinil.
Almost half the patient.
Exactly, compared to just 24.1% in the placebo arm.
Let that sink in. Almost half the treatment group developed a cough from the medication itself. And again, this isn't a once-a-day annoyance.
No.
They are inhaling 12 breaths 4 times daily, coughing through your medication multiple times a day, every single day, when your lungs are already failing and you are already short of breath. I mean, that sounds miserable.
It is incredibly tough. It was like, well, it's like being given a life jacket that keeps you afloat in rough water, but the life jacket is lined with rough sandpaper.
Wow.
Right. Yes, it might be extending your time above the surface, but the minute-to-minute reality of wearing it is physically exhausting and irritating.
That is a vivid analogy.
And that exhaustion clearly shows up in the trial's discontinuation data. A massive 33.6% of the patients in the treatment arm permanently discontinued the study drug before the 52 weeks were up.
Over a third of the patients simply quit, and I assume that was mostly due to the side effects.
Correct. The primary reasons for quitting were adverse events, led by the cough, headaches, and shortness of breath.
Okay, let's do some practical bedside translation for the ICU physicians, the pulmonologists, and the fellows listening to this.
Great idea.
Imagine you are in the outpatient pulmonary clinic. You have a 72-year-old patient with IPF. They are already on pirfenidone. They are noticing more dyspnea on exertion. Their latest spirometry shows decline. And they ask you about this new inhaled medication they read about. How do you frame this for them?
I would anchor the entire conversation in shared decision-making.
Okay.
I would tell them, look, we have strong evidence from a recent major trial that a new inhaled medication can help preserve the lung function you have left. It essentially taps the brakes on the scarring, and it might lower your risk of ending up in the hospital this year.
Right.
But the trade-off is steep. You will need to use an ultrasonic nebulizer 4 times a day, every single day. There's a very high chance it will make you cough, and a third of the people in the study found the side effects so frustrating they stopped taking it altogether.
That's a tough conversation.
It is. And furthermore, I'd have to tell them we don't have definitive proof yet that it extends life.
It is a brutal trade-off. You are asking the patient to balance long-term physiological preservation against immediate daily quality of life.
Exactly.
And for our critical care folks listening, this also has implications for the inpatient side. When an IPF patient gets admitted to the ICU in respiratory distress and you see inhaled treprostinil on their medication list, you need to recognize it for what it is.
Yes, absolutely.
It is an outpatient disease-modifying therapy. It is not an acute rescue inhaler for their current respiratory failure.
That is an excellent point for the intensivists. It is a chronic brake pedal for scarring. It is not an acute parachute for hypoxia.
All right, we have covered a massive amount of ground today, from the cellular stop work orders to the strict rules of hierarchical statistics.
We sure have.
Let's synthesize this to make sure it sticks. Let's bounce through the 5 key takeaways for our listeners to take back to the wards. I'll kick us off.
Go for it.
Number 1. TETON-2 was a positive, rigorously designed Phase 3 trial for patients with idiopathic pulmonary fibrosis, published in the New England Journal of Medicine in March 2026.
Number 2. The primary mechanism of victory was a significantly slower decline in forced vital capacity, FVC, over the 52-week study period. Specifically, we saw a 95.6 milliliter difference compared to placebo. Remember, it slows the disease progression. It does not reverse it.
Perfect. Number 3. Overall clinical worsening was significantly reduced. However, because of the strict hierarchical testing rules, mortality and acute exacerbations were not clearly proven wins in this trial. We cannot overclaim the data.
Number 4. Tolerability and shared decision-making are absolutely paramount. With severe cough affecting nearly half the patients and a 1/3 dropout rate, the daily burden of this 4 times daily treatment is a major clinical consideration for any prescription.
And number 5, for ICU clinicians and pulmonologists, the 2021 INCREASE trial provided the vital background showing benefit in PH-ILD.
Right?
TETON-2 successfully builds on that, proving treprostinil has a pure anti-fibrotic role. But practically, recognize this as an outpatient disease-modifying advance, not a tool that will change your acute ventilator management.
A very solid, actionable summary.
Before we sign off today, I want to leave you with a final provocative thought to chew on.
Ooh, all right.
We started this discussion looking at a drug, treprostinil, that was designed simply to dilate blood vessels, to just open up the pipes.
Right.
But through careful clinical observation and trials like INCREASE and TETON-2, researchers discovered it has a hidden superpower. It acts as a cellular stop work order for physical tissue scarring.
It's amazing.
It really makes you wonder, what other common medications are sitting in our hospital pharmacies right now, fully approved and widely used for one specific task, but quietly harboring secondary biological mechanisms we haven't even thought to test yet.
It is a great reminder that the tools we use every single day might still have entirely new secrets to teach us.
They certainly might. Thank you all for joining us on this deep dive into the NEJM source material. Keep questioning the data, keep listening to your patients, and we will catch you on the next round.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.